CVS Part 1, Case 2.
A 64-year-old man is brought to the emergency department 1 hour after sudden onset chest pain radiating to left arm. He has sweating, nausea, shortness of breath. His past history includes uncontrolled hypertension and hyperlipidemia. He smokes 1 pack per day for last 30 years. On arrival, patient is non-responsive, BP 90/60, heart rate 110, respiratory rate 24, oxygen saturation is 92% on room air. Cardiac examination shows muffled heart sounds, jugular venous distension and pulsus paradoxus. Lungs are clear. ECG shows ST segment elevation in lead V1 to V4 and ST segment depression in lead 2, 3 and AVF. Serum troponin is markedly elevated. Approximately 3 days earlier, he was briefly hospitalized with severe chest pain but refused coronary catheterization and was discharged on aspirin alone. Which of the following best explains this patient's hemodynamic collapse? Option A. Acute transmural ischemia leading to papillary muscle rupture and severe mitral regurgitation. Option B. Necrosis and weakening of left ventricular free wall causing hemopericardium and cardiac tamponade. Option C. Severe anterior wall ischemia producing conduction block in his Purkinje system and cardiogenic shock. Option D. Thrombus propagation in left anterior descending artery with reinfarction leading to myocardial stunning. Option E. Ventricular septal rupture producing left to right shunt with volume overload and hypotension.
So this is a case of transmural MI leading to free wall rupture, hemopericardium and cardiac tamponade. 4 key concepts have been discussed in this case. The first one is the pathogenesis of MI. The second one is the ECG localization of MI. The third one is the mechanical complications of MI, and the fourth one is the management of the case. Now coming to the pathogenesis of MI. What happens once the artery gets blocked, the coronary artery gets blocked, the blood supply to the myocardium will be totally cut off. So this leads to cessation of the aerobic metabolism and depletion of ATP, increased lactate levels, and this further leads to myocardial necrosis. Gradually this myocardial necrosis can lead to the free wall rupture, as in this case. Now this myocardial necrosis invites neutrophil and the other inflammatory cells to come and limit the infarct size to maintain ventricular function. So what is the first step in the pathogenesis of MI which leads to the complete occlusion of the coronary artery? That is the rupture of the atherosclerotic plaque. So the rupture of the atherosclerotic plaque, cessation of the aerobic metabolism, depletion of ATP, myocardial necrosis. The body tries to limit the myocardial necrosis by neutrophilic infiltration, but if not possible or if not done, an ongoing myocardial necrosis can lead to free wall rupture and hemopericardium leading to cardiac tamponade, which happens in this case. Now coming to the second core concept, that is the ECG localization of the MI. So from the ECG, we can locate the coronary artery which is leading to MI. So the most common artery to get blocked is the left anterior descending, the LAD. If the LAD is engaged, which is 40 to 50% cases of the infarct, LAD is engaged, then we'll get ST elevation in V1 to V4, and we might get a reciprocal ST depression in 2-3 AVF also in that case. In the second case where the right coronary artery is involved, which is in 30 to 50% of the infarcts, will get ST elevation in 2-3 AVF. And in third case, that is the LCX, if the LCX is engaged, then we'll get ST elevation in lead 1, AVL, V5 and V6, which is 15 to 20% cases of the infarcts. Now coming to the mechanical complications of MI. So the first mechanical complication of MI is papillary muscle rupture, which happens in RCA infarct. which occurs in 3 to 5 days post MI. And here we can get severe MR. So the second complication is free wall rupture, which happens in LAD infarct, which happens within 2 weeks of MI. So in this case, the free wall rupture will lead to hemopericardium and a consequent cardiac tamponade, which is a life-threatening complication. The third mechanical complication of MI is ventricular septal rupture, which happens again in LAD infarct. And in ventricular septal rupture, there will be a volume overload due to left to right shunt, and we will get a holosystolic murmur in the left sternal border. The fourth mechanical complication of MI is true ventricular aneurysm, which develops after 2 weeks of MI, which leads to generally does not leads to free wall rupture, and we get a paradoxical wall motion in case of true ventricular aneurysm. Now Dr. Sarita will tell what is Bextrad and where do we find Bextrad.
We will find Bextrad in cardiac tamponade. So when hemopericardium, which is pressing the cardiac wall, so which is leading to muffled heart sounds, jugular venous distension and hypertension. These three together known as the Bextrad, which is very important in finding the clinical diagnosis of the cardiac tamponade.
So as discussed, the cardiac tamponade is a life-threatening condition. So with the help of Bextrad, we can timely diagnose it and manage it. Now coming to the management of case. So when we are managing such emergency, then we first do pericardiocentesis to drain the blood which has accumulated in the pericardium. And later on, definitive treatment is done with surgical repair. Particular to this case, we'll be doing pericardiocentesis followed by a surgical repair of the free wall rupture. And in other cases of MI, we'll look for hemodynamic stability followed by reperfusion therapy with PCI and thrombolytics. Now coming to the exclusion of the options. Option A is ruled out because it is not a papillary muscle rupture. Option C is ruled out as there is no conduction block and cardiogenic shock in this case. Option D is ruled out because the thrombus propagating the LAD leading to reinfarction and myocardial stunning is not happening here. And option E, what is option E?
It's a septal rupture.
Septal
ventricular
rupture. So,
septal rupture.
as we see that interventricular septal rupture is not the cause for the cardiac tamponade here, it is the free wall rupture. So option B is the correct option. That is the ongoing myocardial necrosis, not being able to get limited by the inflammatory process, and the ongoing myocardial necrosis will lead to free wall rupture, leading to hemopericardium and a consequent cardiac tamponade. Thank you.